To my knowledge, there are the other two AR receptor antagonists being studied, the darolutamide and enzalutamide. Enzalutamide is the one that's already FDA approved for metastatic castration-resistant prostate cancer. There are also immunotherapies being tested in the biochemically relapsed space. If next generation AR receptor antagonists are approved, I would recommend them in non-metastatic castration-resistant prostate cancer, simply because they delay the time to metastases, which are what give the patient symptoms. I would, of course, have a discussion with my patient. I can see some patients opting to wait on those therapies, but I would recommend it. So if and when I start patients on these AR receptor antagonists, I would look for A, fatigue, B, worsening of any symptom that the patient had on leuprolide acetate alone. C, I'd be very careful about following their bone density, since these may accelerate loss of bone density. D, I'd be looking for any seizures and cognitive dysfunction. And E, falls, I think, are a big deal, especially since prostate cancer patients are elderly and have decreased bone density to begin with. Multimodality treatment, to me, means including physicians from different specialties like radiation oncologists, surgeons. I'm not sure that they do play much of a role in non-metastatic castration-resistant prostate cancer. But you could also look at multimodality as other cancer treatments too, like perhaps immunotherapies and chemotherapies. And I don't think that they play much a role either in this situation. At this point in time, the patient clearly has metastatic disease, since that's defined as seeing a tumor on a scan. I'm glad he's asymptomatic, and it does shape my choices here. My impression is that he's now appropriate for any number of therapies. I'm most likely to start one of the hormone therapies, such as abiraterone or enzalutamide. The patient has many treatment options at this point. Once a patient develops metastatic castration-resistant prostate cancer, there are 6 treatments that improve survival, including 2 chemotherapy drugs that I'm unlikely to recommend at this time because he doesn't have symptoms. There's abiraterone to do more complete suppression of androgens, enzalutamide to block the androgen receptor from binding to testosterone, and there's also sipuleucel T, which is an immunotherapy appropriate for patients without symptoms. Down the road, we could do radium-223 if and when he develops bone pain. So this patient has gone through just about every phase of the disease. First, he had localized prostate cancer, which he did everything in his power to get cured, but unfortunately it came back. Then he developed biochemically relapsed prostate cancer, and then castration-resistant non-metastatic prostate cancer. So at the situation of the non-metastatic castration-resistant prostate cancer, I hope and believe in the future we'll be able to use our second-generation androgen receptor antagonists in that space. And then at the development of metastatic cancer, we have all those other treatments that we can use. So in the future, what will we be doing? I think for the non-metastatic castration-resistant prostate cancer, for the time being, using the hormone therapies, as we discussed. I'm looking forward, though, to newer immunotherapies that might be useful to wipe out the disease while the volume's still low. And for the metastatic portion of his disease course, I do hope that in the near future, through combinations or novel agents, we'll be able to cure some patients.